So today we'll be discussing about the Hrct chest. Now this is a very interesting CT scan of the chest. This is high resolution non-contrast CT scan. So we definitely know that this patient had history of injury. So this is always the left side and this is always the right side. So just see or just compare, this is basically the left lung. The black is all lung. This is more of a radiolucent or more of a black compared to this which is white. This blackness is because of the air, and air appears black on CT scan. CT scan is basically X-rays. So this is left lung, this is right lung. So just compare that. Ideally actually bilateral lung should be almost of same size, but in here what we can see, this is the left side, and on right side we cannot raise the lung margin here. We cannot raise the lung margin here. So what we can see in on the right side is this all is more of a very dense black. Actually there should have been lung or this area, but the lung is not there, and there is a very dense black structure, and the most radio lucent structure or most black structure on X-ray is air. Just compare, this is outside of the body and this is all air in the room. This is all air in the room. This all black color is all air in the room. This is as black as this. So this is typically air which is present outside the lung, inside the body. These are the ribs, the dense white structure. These are ribs. You can see this is rib. This is rib. So inside the rib and over the lungs you have a dense black air. So this is a very typical CT scan of pneumothorax. This is typical pneumothorax, which is simply compressing the right lung completely, so that almost this much portion is all compressed. And you can see, just compare the left lung and the right lung, there is so much of hyper dense or whitish lining present, which typically presents or typically tells that this lung has contusional injury. Whenever lung gets injured, whenever lung gets blunt trauma, the radiolucency of the lung reduces and you get radio opaque white lines. How it present is with desaturation, because this lung will not contribute to oxygenation. So the oxygenation of the patient may reduce. So in these patients may have bleeding through the endotracheal tube or through the nose or through the mouth, because this contusion in the lungs will cause rupture of so many blood vessels which are supplying to the bronchi, alveoli, and that blood will directly come through the bronchi, through the trachea, out through mouth or nose. So those patients who have contusion to the lung will have hypoxemia, reduced oxygenation, tachypnea. These patients will have increased respiratory rate. These patients may need non-invasive ventilation or invasive ventilation depending on stability of the patient, and these patients are usually put on steroid, because these patients are put on either around 300 milligram of hydrocortisone, or up to the weight of the patient we can give methylprednisolone. So if the patient's weight is around 80 kilogram, we can give up to 80 milligrams of methylprednisolone. So why this steroid is given? Because of the lung contusion, there is significant release of so many inflammatory chemicals in the lung, and the patient may rapidly land up in acute respiratory distress syndrome, or the patient may rapidly land up in cytokine storm. So to prevent this, patients are usually put on steroid. If the patient have lung contusion, if the patient have bleeding through the lungs or bleeding through the trachea, and for this much of pneumothorax, serial X-rays can be done, or if the patient is stable, if the patient's saturation is maintained, if the patient doesn't have a huge tachypnea, if the patient's RR is not more than 24, then high flow oxygen can be given through NIV, non-invasive ventilation, or invasive ventilation, or the patient can also be given oxygenation through NRBM masks. And if it is needed, or if the patient's saturation is less, if the RR is more, if the tachypnea is there, or if the patient is unstable, then an ICD can be put, intercostal drain can be put to relieve this pneumothorax. Usually, when the ICD is put, after 24 hours of putting the ICD, the X-ray is taken. If X-ray shows marked improvement in the pneumothorax, usually very commonly after 48 hours, if pneumothorax completely resolves, then ICD can be removed, or the ICD is clamped for 24 hours and again an X-ray is taken. If the X-ray does not show any pneumothorax, then ICD can be safely removed. If ICD is clamped and after some time if the saturation reduces, or the tachypnea worsens, or if the respiratory rate worsens, and if the patient shows increased pneumothorax, then ICD has to be unclamped so that the air which is getting accumulated outside this lung, compressing the lungs, can be reduced. Now, when do we call it as tension pneumothorax? It's very simple. Whenever there is marked accumulation of this free air outside the lung, compressing lungs and compressing heart as well, because see, these are the lungs, this is left lung, this is right lung, and where is the heart? This is all mediastinum, this is all heart, this is all heart. So if there is so much of air which is compressing the heart, then automatically the blood flow to the heart will be reduced, because it will simply compress not only the atrium but also the ventricles. So because of the pressure over the heart, the blood flow in the heart will reduce, so automatically the stroke volume will be reduced, automatically the blood pressure will fall, and automatically the patient will again worsen. So if there is significant amount of air which is accumulated outside the lung, compressing lung, and as well as if it is causing shifting of the mediastinum or shifting of the heart, or if it is putting significant strain on the heart, so as the blood pressure is getting poorer or the stroke volume is reducing, if the pulse volume is becoming feeble, then that is called tension pneumothorax, and that is one of the emergency indication of putting the ICD. Now we can see that this patient not only has the pneumothorax, which is presence of air in the thoracic cavity, but this patient also has subcutaneous emphysema. Subcutaneous emphysema means, see, when we zoom in, see, this is bone, this is dense white structure, this is bone, this is vertebra, this is ribs, this is rib, and this white this slightly radiolucent or blackish structure is all fat. This is all fat. We know dense black structure like this is air, this is air, this is air, this is also air, and at the same time this dense, not that much dense, but it is kind of blackish or radiolucent structure is fat. So this is all fat which is present here. You can see this is fat, this is fat. So this is fat, and above that we have a skin. So in this, below the fat, around this region, we can see that there is accumulation of the air, which we call it as a surgical emphysema. And this can be very easily appreciated by pressing over this area by hand. If you palpate or if you press by hands, we can see crackles, we can hear crackles or crepitus, which is a very typical feature of subcutaneous emphysema. So if the patient has tension pneumothorax, then definitely this surgical emphysema has to be relieved by giving multiple horizontal cuts, and we have to remove the air which is trapped inside the subcutaneous tissue, but that is applicable only in tension pneumothorax. If the patient does not have tension pneumothorax, it can be managed completely conservatively. So this is a very interesting case of a road traffic accident with not tension pneumothorax, but with pneumothorax, contusion of the lung, with collapse of the lung, with not significant shifting of the mediastinum. See, there is no significant shifting of the mediastinum because this is main right bronchus, this is main left bronchus, so they are almost in the midline. So this is not compressing, this is not transferring the mediastinum to the right side. This mediastinum is almost in the center only, because this is the right main bronchus, this is the left main bronchus, and this is almost in the center only. So if there would have been tension pneumothorax, this both right, left and right main bronchus would have been like on this side. So the mediastinum is present or perfectly in the center. There is no shifting of the mediastinum to the left side. It means that this is not tension pneumothorax. That's all for now.